This is Mark Scrimshire with how the HL7 FHIR spec and what's going on at the Connectathon fits into the ONC and CMS rules.
Okay, hello everybody. It's heading to like 80 degrees today and we're not in landlocked San Antonio. So I thought, why the hell not? Let's have a surfing theme since we're surfing the web virtually these days. I'm going to talk about HL7 FHIR and how it relates to the ONC and CMS rules that were released really back on March 9th. So the ONC rule is the Interoperability Information Blocking and the ONC Health IT Certification Program, which is a real mouthful. And the other one is the CMS Interoperability and Patient Access Rule. I'm going to mainly focus on the CMS rule because that's what I've been living and breathing for a number of years in my role as the CMS Blue Button Innovator. And so I'm going to try and give you some of my perspective of what I see, how FHIR can be used by primarily the payers to meet the requirements that are there in the interoperability rule. So, like I said, I'm not going to focus too much on the ONC. If I had to summarize that, the real key point with the ONC rule is really leveraging from the Cures Act, which is focusing on really breaking down those information blocking barriers. So I think a lot of the focus around the ONC rule is you know, what are legitimate controls, but trying to open up the flow of information. The CMS rule becomes has a slightly different focus. It's focusing on the sectors of the healthcare market that CMS regulates, but both the ONC and the CMS rule are really about improving transparency and improving access to information, particularly for consumers. And if you read between the lines of the ONC, the CMS Act, what it really is saying is it's building towards a longitudinal health record. The idea being that as I move from one health plan to another, which we often do here in the US, that we're able to say, I want you to go and get my health record details from my last plan. But equally, the important part of the CMS rule was the fact that it was not only covering payer-to-payer exchange, but it was also covering payer to third-party application. So I, as a consumer, could choose to have an app, a personal health record app or a health record exchange type app, where I can aggregate my data. And now that through the work of the ONC, where most of the EMRs are meeting meaningful use certification from 2015, which basically made the Argonaut DSTU2 profiles available to consumer apps. There are now the ability to go to like 10,000 locations in the US, and if you have an account, be able to gather your data. So that starts to create the ability to aggregate that data. But health plans have been largely outside of that. And the CMS rule is really about unlocking the data that is there that health plans have. And I often call the claim history of a consumer as like the connective tissue of the care journey. It may not be very deep, but it is very broad. And as such, what you can do is, as we address other challenges in the healthcare industry of where are all these API endpoints, we can start to think about the fact that the claim history would allow you to identify where someone went, what plan it was covered by, but also who was involved, which, for example, the NPI of either the organization or the provider, which if you had a directory of where those providers and organizations are registered and where their API endpoints are, if you have the right credentials, you could reach across and go down and grab the clinical record and merge it back with the claim record. So this all moves towards creating the next generation of problems for us developers, whereby, you know, we are going to have to deal with how do we actually make sense of all this data? How do we clean it up? How do we work out which are duplicates, and so on and so forth? And I think FHIR can help us with a lot of that, with the way that we can, for example, have multiple identifiers for a patient. But the key point is, if you are a payer and you are looking at what do I have to do to meet the demands of the interoperability and patient access rule, if you are just looking at just meeting what it says in the regulations, you're missing out on real business opportunity. You see this move to this longitudinal record. A lot of people have misinterpreted the 5-year rule that was in the proposed rule, and people were thinking, I only have to make 5 years worth of data available. That's not actually the case. If you read the rule, it is really implying that as a health plan, you will maintain data going back to January 1, 2016. And the rule is really saying, if I, as a consumer, leave you as a health plan, anytime in the next 5 years, I can come back to you and say, give me my health record, or send my health record to this new payer, for example. So when we look in 2021, when we're implementing this, or in 2022, or look out into 2025, you will still have a requirement to make that data available back to January 1, 2016. So in 2025, there'll be effectively 10 years worth of data. So the point being that you only have to make it actually accessible to somebody that has left within the last 5 years. So it's important to understand that. So the other side of this is, how does all the work that we've been doing in both the CARIN Alliance and Da Vinci and the general FHIR community all fit together? And there are effectively really 5 components when you look at the CMS interoperability and patient access rule. They talk about a couple of things. Let's start with the items on the left. There is a requirement that you have an open API that it basically expresses your provider or service directory. So I, as a member, can use an app to go and look at this API and maybe determine what providers are in my area, what providers are in my plan, or I'm thinking of moving to your plan, but is my provider in your network, or am I going to be out of network? All these have an impact on the costs to a consumer. So the provider directory will allow these and other types of searches to happen. And I know MITRE have been running the Connectathon track in conjunction with the next one, the PDEX-Formulary track. So the PDEX-Formulary APIs, as a payer, as you know, you have a formulary, and that defines which drugs are in which tier, which again affects the consumer's costs. And so the rule basically requires you to make that information available as an open API, so that it can be queried by third-party applications. And so again, it really plays into, and we've actually seen this on the CMS Blue Button. A lot of apps have been developed that will look at a beneficiary's history, and then can take the medications and diagnoses and conditions, and then go and look at plans information and work out, given their actual health history, what's the best plan? What really meets their needs? You know, are the drugs that I need on a regular basis in the most expensive tier, or are they in the cheapest tier? That has a real impact to the bottom line for consumers. So there's the 2 open APIs. Then the next 3 are really where you have to enable a member to identify themselves and choose to share their information with an app or another payer. So they may choose a personal health record app, and the data really falls down into three areas. There's claims history, there's encounter, and there's clinical data. So the claims is really covered by the CARIN blue button IG, and so there you're dealing with patient records, coverage records, and explanation of benefit records. And so that will enable a consumer to share their information with an app, and then you can look at the relative costs and other aspects of those claims. The other side of the rule is to say that plans also need to make available any clinical or encounter data that they have. And so that's where we are really looking on the payer data exchange IG. So the difference between the CARIN blue button and the PDEX implementation is really that CARIN is looking at the financial aspects of the patient's history, and PDEX is looking at how payers can release the clinical data that they have, either derived from the claim, for example, the medications or the diagnosis codes or conditions that are incorporated into the claim, or they may have information that they get from sources, whether it's ADT messages or whether it's lab results that they get in bulk from a lab partner. And it's a case of making that information available. And what we're doing with PDEX is saying, let's put that into US core resources, because many parts of the industry, particularly the EHR market, are dealing with US core resources. So we're trying to avoid payers having to create multiple different formats for the same data. And we're also trying to make it easier for developers that are trying to consume this data to have fewer profiles to have to deal with. So very quick, that's a very quick run through. I think we've done that in about 12 minutes. I think we had 15 minutes. I'm certainly open to other questions, and I would be happy to take those. You can either get me on Twitter at eKaiVMark, or you can reach out to me via my email address, and we'd be happy to talk to you about the implications for payers as they gear up in 2021 to release information to their members, and in 2022 to accommodate the payer-to-payer exchange that's covered in the interoperability rule. So with that, I think I can hand back to you, Sandy.